So we'll today talk about neoadjuvant therapy in pancreas cancer. So mainly because of some recent data that has been published. Let me know what else you would like to discuss. Next week, I would want to complete the topic by talking on adjuvant therapy of pancreatic cancer, because there are a lot of stories, SPAC story, the CONCO story, which is to do with plus or minus radiotherapy and why we actually no longer use adjuvant radiotherapy in most of our patients with pancreatic cancer. But for as far as neoadjuvant therapy is concerned, I think there is good data that is coming up with radiation as well. So I'll try and finish neoadjuvant therapy today, and we'll talk about adjuvant next week. So most of our patients who come to us with a diagnosis of pancreatic cancer are quite elderly, with the median age being 71 years. But because of the population matrix, we know that most of our patients in India are a decade earlier. We do not have the exact statistics for India, but this is from the Western data. Very important when you have a new patient with adenocarcinoma that you define resectability. And I would want you to read the guidelines. NCCN 2020 has again updated the guidelines. And so you must look at the venous abutment, whether the contact with the vein is less than 180 degree or more than 180 degree. So it's important right at diagnosis that you have a very good radiology colleague and know what is resectable, what is unresectable, and even those where you have resectability, whether it's borderline resectable or locally advanced. Any arterial encasement or involvement makes the tumor locally advanced. So, and again, you need to know what the oncologic risk is. If it's a small size, low CA 19.9, CA 19.9, if the patient is not jaundiced, can be prognostic as well. And also we know that patients who have head tumors tend to do better. And mainly possibly because they are diagnosed earlier. So also most of the patients that we see in India, I know there are students from abroad as well, are periampullary. So we will discuss periampullary if you want as a separate in a separate meeting. So periampullary is the region around the ampulla. So you may have a cancer, so which is pancreatic in origin, or you may have it which is biliary in origin or intestinal in origin. And the prognosis of patients who have an intestinal origin versus pancreatobiliary origin is different. So I think by various immunohistochemistry methods, you would be able to differentiate whether the patient has what origin the patient has for the tumor. So we will not discuss that today separately, but we may take it up with the adjuvant story next week, because again, the reason why it is important is because the prognosis for periampullary cancers is better. So most of the papers that have been published, the surgical papers from Tata Hospital, you would have seen that the outcomes are slightly better, and that is because most of the patients have a periampullary cancer. Median survival, reaches 12 months in advanced cancer now because of the use of FOLFIRINOX and gemcitabine nab-paclitaxel. So we never talked beyond 6 months till both of these results came out. So important to know resectable, it's still, the results, despite a lot of advances, are still not very good. For my non-surgical colleagues, very important, you understand what Whipple's is, or a PPPD, we call it, pylorus preserving pancreatoduodenectomy. So as you can see that with the removal of pancreas, there are a lot of anastomosis that the patient has. You have a bile anastomosis, you have stomach attached to the small intestine, the remaining pancreas is attached. I will not discuss the surgical complexities, But the only reason I'm showing you this slide is that this surgery is one of the most complex surgeries that you have in cancer. And the patients do have an attached mortality and morbidity associated with it. And so hence it's very important that before we consider this major surgery, we are very sure that the patient is going to benefit from it. And that's why we are discussing the neoadjuvant therapy first. So as you will see from the evidence that I will present, the reason why neoadjuvant therapy first, probably better for the patient. That's number one. That's why we generate all the evidence. The rates of R0 resection are higher. There are less of pancreatojejunostomy leaks, and there are various papers and evidence related to that. Also, as you will see that in most of the trials and in real life as well, you will see that about 50% of patients do not even get to adjuvant therapy. And of those who get to it, very few of those complete all of the adjuvant therapy. But I think the most important thing is that you can test chemosensitivity preoperatively in these patients. Also about the micrometastasis story I'll talk about. As you can see from these studies, the SPAC4, about 50%, 50 to 60% patients do not actually get to adjuvant therapy. Also, if you look at the node positivity and the R1 resection in the PRODIGE trial was the FOLFIRINOX trial. So the rates of R1 resection and the node positivity are quite high in patients who have surgery followed by adjuvant therapy. I know in breast cancer, in rectal cancer, we do not accept, or even cholangio, we do not accept R1 resection. But so I think we have to start thinking like that in pancreas to try and decrease the R1 resection rates. Again, the rationale, as you can see here, again, it shows it very well. This paper, some of these studies are published by the MD Anderson group, that patients who develop disease progression probably do not need pancreatic surgery. And if you look at the curve, so patients who had neoadjuvant therapy only, no surgery, the survival is 11 months compared to those who had neoadjuvant therapy and surgery, which is significantly better. So also we've learned from quite a few studies that if the tumor is abutting any of the vascular structures, the risk is very high. So, I mean, I've debated quite a few of my colleagues about giving neoadjuvant therapy in resectable pancreatic cancer, but for borderline pancreatic cancer as well, because every surgeon feels differently. And the standard of care as per the guidelines has been upfront surgery for borderline pancreatic cancer as well. But as you can see, the R1 resection rates are very high if the patients do undergo surgery. So this is a very good computational model for pancreatic cancer. Basically, it shows that pancreatic cancer is a systemic disease. So even if the tumor is 2 centimeters in size, the chances of metastasis, micrometastasis, is about 70%. So why would you not consider systemic therapy before you take the patient up for surgery? So, I mean, I think a few decades ago, we know this was the pivotal study which showed us that gemcitabine alone is better than 5-FU. This is in patients with metastatic pancreatic cancer. Hence, gemcitabine has remained the standard of care. Now, the downsides of neoadjuvant therapy are also important to discuss. So it's possible that we could lose the window of opportunity for curative operation. So I think in breast cancer, we've learned, and most of the guidelines also support that. So when a patient is on neoadjuvant therapy and they start progressing, we actually proceed with surgery sooner rather than later. So whether we should do the same or whether we should not, but you cannot compare breast surgery to pancreatic surgery, which has a high morbidity of up to 50 to 60% and has mortality attached to it as well, unlike breast surgery. So also for neoadjuvant therapy, the other downside, which I'm told by quite a few, is it requires preoperative biopsy. And I know that in about 10 to 30%, based on various studies, you're not able to get enough material to be able to start neoadjuvant therapy. You don't need histology for the patient to proceed with surgery if you have radiologic features of pancreatic cancer. Also, they may need biliary decompression and stent management, so that also adds to complications. So also it's important for us to remember that further improvements in surgical treatment are not going to improve outcome, because I think our Japanese colleagues have done celiac axis reconstructions. Our surgeons are now doing portal venous reconstruction, SMA, arterial reconstructions as well. But with each of these reconstructions, we know that the surgical morbidity is very high. So I don't think there would be any further improvements in surgical treatment. So to be able to improve the outcome for our patients, I think it's very important that we think of addressing the micrometastasis by neoadjuvant therapy previously. And we do have very good systemic treatment options, as we know. So post-op complications, again, this systematic review of about 30 trials actually looked at all the complications associated with pancreatic surgery and showed no significant increase in complication rates in those patients who had neoadjuvant treatment. Now, coming on to, it's a great time in the last, I think, 2-3 years. We've had fantastic presentations on neoadjuvant and total neoadjuvant therapy in pancreatic cancer. This study, PREOPANC-1, the Dutch trial, was presented at ASCO 2 years ago in 2018 and has been published just last month. This is a randomized phase 3 trial in patients with resectable and borderline. So just remember, this is two different group of patients. This trial also had borderline resectable pancreatic cancer. And basically, patients were randomized to surgery followed by 6 months of gemcitabine versus gemcitabine radiotherapy followed by surgery versus 4 more cycles of gemcitabine. And it's 1 grams per meter square. Primary endpoint was overall survival. And as you can see from this study, that with the addition of chemoradiotherapy, there is a significant downstaging, with the R0 resection rate being 63% versus 31%. Disease-free survival was significantly different, though it did not meet its primary endpoint. If you see here, with the survival, the curves for overall survival are on top of each other. The p-value is 0.09, so it did not meet the primary endpoint. But for disease-free survival, it was significantly better. In loco-regional control also, it was significantly better. So in this study, the authors in the conclusion say that a predefined subgroup analysis did show a superior overall survival with preoperative chemoradiotherapy for borderline resectable pancreas, but not for resectable. And also you would see that the results are slightly different compared to the adjuvant trials. And what they have said is that patients who had chemoradiotherapy was along with surgery, there was a significantly better, who completed the treatment, there was a significantly better overall survival. But again, I would say this was a negative trial because it did not meet its primary endpoint. But all of these data look very encouraging in a disease which we know is very difficult to treat. There was this Japanese study as well, which JSAP-05 or PREOP-02, which in resectable patients randomized patients to gem S1. I know S1 is like 5-FU, it's like a fluoropyrimidine, followed by surgery, followed by S1 versus surgery, followed by adjuvant therapy. And what they wanted to look at was the resection rate in these patients. And the resection rate with upfront surgery was 82% versus 93% in the neoadjuvant arm. And So it did meet its primary endpoint. As you can see, the median overall survival was also better, with a hazard, it was a 30% benefit in patients who had neoadjuvant chemotherapy versus those who had upfront surgery. And the phase 2 actually led on to the phase 3 study, because it showed that there was sufficient resection rate, and with neoadjuvant therapy, the treatment was not compromised for surgery for most of these patients. Just comparing these two trials, as you can see, Priopanc also had borderline resectable. So radiology review in identifying these patients is very, very important, especially if you're doing a randomized trial. So the Japanese trial had it, and as you can see that the primary endpoint of was 14, median overall survival of 14 and 16 months was not met in Priopanc, but it was met in the Japanese study. So I think it's fair enough to say that the perioperative arm did significantly better in the Japanese trial. And we'll discuss two more studies which were presented at ASCO this year. Meta-analysis, again, I won't discuss too much into it because these are old ones. They also, quite a few meta-analysis do recommend neoadjuvant therapy in resectable and borderline resectable cancers. So if you look at this systematic review, which looks at life expectancy, and again, we always say that, for a patient, only two things matter. It's how long to live and what the quality of life is. And this analysis showed that neoadjuvant therapy resulted in a higher life expectancy of 32 months versus 26.7, and also resulted in higher quality adjusted life years. When you work in a universal health coverage system, all of these are very important to have treatments approved. Again, another propensity score matched analysis also showed that neoadjuvant therapy has significant downstaging on T stage, the lymph node stage, and the resection margins. And I think it would be good if you read some of these papers, which will convince you to consider neoadjuvant therapy in most of your patients. So another same paper again showed that it improved overall survival compared to surgery alone versus surgery plus adjuvant therapy. Coming on to the two studies which were presented at ASCO this year. SWOG study looked at patients with the resectable pancreatic cancer with a good PS 0 to 1. They had modified FOLFIRINOX, and every 2 weeks for 6 cycles or 12 weeks, that's 3 months of therapy, versus Gem/Nab-Paclitaxel. And we know that from the metastatic setting that these two are the most effective treatments that we have available today for patients with pancreatic cancer. So they had these treatments for a similar period for 3 months, had restaging, and proceeded to surgery if there was no progression. And after that, then they had 3 months each of more of the same treatment. And baseline scans had a central radiology review for eligibility. The primary endpoint is, I won't go into the statistics, but it looked at a 2-year overall survival rate for more than 58%. And if you look at this study, the 102 patients, 55 and 47 in both the arms. So it was quite heartening to see that 70% patients underwent a resection. So 73% in the FOLFIRINOX and 70% in the Gem/Nab-Paclitaxel arm. And again, it remains challenging to start chemotherapy after surgery. As you can see, about 50% patients started post-op chemotherapy, and about 40 to 49% patients completed post-op chemotherapy. Sadly, the toxicity was pretty similar in both the arms. So very important to remember that these are very good performance status patients. So the target was 58% at 4 years. It did not meet it. The curves are literally on top of each other. The 2-year survival was about 43 and 47%. So, but the one thing that that if you see here, the complete or major pathologic response was 25% with FOLFIRINOX versus 42% with Gem/Nab-paclitaxel. Again, there was no central pathology review for this, and hopefully in a trial that is so well run, probably they should have had a central pathology review. But this does give food for thought, and it is hypothesis generating. R0 resection was pretty similar in both the arms. Node negative resection was pretty similar. The disease-free survival was 11 months with FOLFIRINOX and 14 months with Gem/Nab-paclitaxel. So I think the authors concluded that the 2-year survival rate was pretty similar. It did not meet the pre-specified threshold. And they felt that both these regimens are pretty safe and are feasible to deliver as neoadjuvant strategy. This overall survival was similar in both the arms. So central radiology review is very important for finding out the study eligibility. The second study, which was very interesting and presented at ASCO this year, was the ASPAC-5F study. So these were all the patients with borderline resectable pancreatic cancer. They were randomized to surgery alone, which remains the standard of care, versus GEM-CAP. We know from the ASPAC-4 study that GEM-CAP, we'll discuss next week, is standard adjuvant treatment for patients with pancreatic cancer, versus neoadjuvant FOLFIRINOX versus. So again, the duration is pretty similar. GEM-CAP 2 cycles is 8 weeks of treatment, and neoadjuvant FOLFIRINOX is given 2 weeklies, again 8 weeks of treatment. They had a scan. If there was no progression, they had surgery, then adjuvant therapy, and then had a 12-month of follow-up. This is a prospective randomized study. Primary endpoint was recruitment rate and resection rate. So the study recruited pretty fast. So that shows that there is a lot of desire for us to improve outcomes. So overall survival, this was one of the secondary outcomes, but I think it is very important that patients who had immediate surgery, the 1-year survival was 42% versus 72%. So you can easily see that the curve for neoadjuvant therapy is higher up compared to those with the upfront surgery. And it's reflected, the bottom curve is for upfront surgery, and these three are for the 3 strategies for neoadjuvant therapy. So again, this is a summary slide which was presented with Dr. Sai at ASCO. So 2 months of neoadjuvant therapy was very well tolerated. About 75 to 90% completed the neoadjuvant therapy, more so in gemcitabine, capecitabine compared to the chemoradiotherapy and FOLFIRINOX. And we know that gemcitabine, capecitabine is easier to deliver for most of our elderly patients compared to FOLFIRINOX, which is quite difficult. Then there were 32 patients who were not resected, either due to progression or they were offered surgery and not resected. So again, how long from central review until start of therapy? I think this is very important. It's very important for all the clinical trials that you see that you question each of the, these results are practice changing and the trial is very important. But I think we have to learn and move on to see if we can do even better for our patients. So again, compared to the retrospective data, about 55 to 60% patients were offered surgery and resected. R1 resection rates are very high, despite neoadjuvant therapy. So except in the chemoradiotherapy, where it's 63% compared to 82 to 81%. So chemo itself alone has not made much difference in the margin resection, but again, the numbers are very small. So node positivity, again, significant downstaging with chemoradiotherapy compared to chemotherapy alone. 1-year survival of 42% with surgery versus 77% with chemoradiotherapy. So if you put all of these studies together, you have the PREOPANC, which had some borderline resectable, and SPAC, and this, you will see that most of the 80 to 90% of patients do complete their treatment. And the other take home message from this is chemoradiotherapy causes the most downstaging as far as R1 and node positive resection is concerned. So it's quite possible that most of our patients will need chemotherapy followed by chemoradiotherapy followed by surgery. And I think the Alliance trial is looking at that. So most of these institutions, this slide also shows, is, are going towards chemotherapy, whether you go for gem-nab paclitaxel or whether you go for modified FOLFIRINOX is the main question now. And the PREOPANC 2 that is recruiting onto that and hopefully will answer that, followed by radiotherapy, followed by surgery. So, or you can have chemo, radiation, followed by chemo, surgery, followed by chemo. So all of these strategies, like we discussed in rectal cancer, so total neoadjuvant therapy is where we are heading towards in pancreatic cancer. Key things for us to remember pre-treatment and on treatment are very important, that you have a good radiologist who has a good understanding. Should avoid an endoscopic procedure before imaging. Again, radiologists can't stress it enough. Have a structured reporting template. You need to know what the association of your tumor is with the SMA, SMV, portal vein, and all of the arteries and veins surrounding that. And imaging should be done within 4 weeks of starting therapy. That is very, very important. For jaundice, I think if you do EUS, try and get some histology, brush cytology, in case the patient needs to go for neoadjuvant therapy. So try and do EUS and ERCP at the same procedure. So use uncovered metal stent for durable biliary decompression. I won't go into the discussion about that because there are a lot of pros and cons of various things. Aggressive supportive care, use of Creon, very important nutritional rehabilitation for your patient. I can't stress it more, is very important for the patient to get on to adjuvant therapy and also tolerate neoadjuvant treatment. And also we should be willing to dose reduce when we have any grade 3 toxicity, because the incidence of grade 3 toxicity can be very high with both gem-nab paclitaxel and FOLFIRINOX. So I think accurate staging, very important. The SWOG study showed us that FOLFIRINOX and gem-nab pacli when given are equal. SPAC5F has showed resection rates with the upfront surgery and neoadjuvant therapy are pretty equivalent. So if you have questions, don't hesitate to. So Creon is, if especially, if a patient is not thriving, is losing weight, you have to ask the patient if the stools are floating, because a pancreas produces enzymes and the enzymes help you digest the food. And if you have taken most of the pancreas out, then the patient will not be able to digest the food and will keep on losing weight. So that's why you need to give Creon. I recently had a patient who kept on losing weight, was on 25,000 Creon 3 times a day. And despite that, the stools were floating and the patient had lost about 10 kilos. So even with snacks, we asked him to take 10,000 units. And with that, the patient, after, when I saw the patient 4 months later, at least the patient has stopped losing weight and hopefully will start gaining now. Very briefly, I'll talk about locally advanced pancreatic cancer. Just a study, there's a scallop trial as well, which again showed that capecitabine is probably better than gemcitabine. Then you had this LAPO-7 study, which actually made us think that whether we should give neoadjuvant radiotherapy to patients, because the trial was negative. And we know that adjuvant radiotherapy trials have been negative as well. So there was quite a lot of skepticism about considering radiotherapy. So this was unresectable locally advanced patients. First randomization, patients were randomized to gemcitabine erlotinib versus gemcitabine alone for 4 months. And if there was no progression in about 61% patients. So now we know that gem alone is not the right So it's an old trial. That's why I'm not going into the details of these studies, because we no longer use gemcitabine alone. And we definitely don't use erlotinib at all. They were randomized to gem alone versus capecitabine radiotherapy versus gem erlotinib. The primary endpoint was survival, overall survival, and the trial was stopped early by the data monitoring steering committee, as boundary for futility was not reached with CT chemoradiotherapy. And the median survival was 16.4 months with gem erlotinib versus 15 months with cape radiotherapy. And it was found to be non-superior to chemotherapy, and the trial was stopped. I wish the trial had continued accruing, and we would have known probably more about this. Erlotinib did not improve overall survival as well. This phase 2 LAPACT study design, again, unresectable, locally advanced patients, good PS, received 6 months of gemcitabine nab-paclitaxel, and if they did not have progression, they either continued on this, or they had chemoradiation, or they underwent surgery. And basically the bottom line I wanted to show with this slide is that the 15% patients were converted to have resection with this approach. And possibly if you intersperse it with the radiotherapy, especially with the newer radiotherapy like SBRT and other forms, more accurate forms of radiotherapy, probably the resection rates would go up even more. So again, a lot of emerging role for SBRT in locally advanced pancreatic cancer. If you want somebody to take a class on this, I'm very happy to ask one of my colleagues, Vinita, or somebody to come and talk to you. Again, I can't understand this, but this basically shows that that radiation is very accurate nowadays. So locally advanced, again, this paper on pancreatic cancer showed that the response rates were about 30 to 40%, and they achieved resectability in 60% of patients. Now, always remember, when you're looking at single center studies, always look at it with a little bit of skepticism, because single center studies are, that's why we do randomized trials, which are the gold standard for changing practice. So this is from Professor Buechler's group. So overall, I would say that FOLFIRINOX response rates are about 30 to 40%, 20 to 30% with SBRT and gem-nab-paclitaxel. So, you know, the good thing in pancreatic cancer is now we are talking of a PAT-CR. And one of the first patients I had a PAT-CR was with, I will just talk about it, with gem-cisplatin. So how important it is for a patient to attain a PAT-CR. So as you can see that, you know, if a patient has a major response, that patient will have a significantly better outcome than those who do not. So again, this is the rule in most of the studies that we do in other cancers as well. So if you look at this small retrospective study, all these patients had FOLFIRINOX, you know, 14 had borderline resectable, 14 locally advanced, 1 oligomets. So according to this paper, all the patients are alive. The majority of recurrences were distant metastasis. No difference in survival was seen in patients who received adjuvant after complete pathologic response. So, so now we are discussing in pancreatic cancer whether you actually need to give adjuvant therapy after the patient has had a pathologic response. And I think the only take-home message for me here, for you guys here, is that we are talking of PAT-CR in pancreatic cancer, which is a huge development for us. Very briefly, I would wanted to just mention this in 2 slides, that all patients with pancreatic cancer should undergo BRCA gene testing or PALB2 gene testing or a hereditary mutation testing, because there is a treatment implication. So these patients would respond very well to a platinum-based blazed treatment. So if you look at the germline mutation panel testing in pancreatic cancer, it ranges from about 5 to 9, 12%. So this is important in early pancreatic cancer, for mainly for whether you would want to consider cisplatin or FOLFIRINOX, which has oxaliplatin, as your neoadjuvant regimen, Or in advanced pancreatic cancer patients, the POLO trial has shown that these patients can receive a maintenance olaparib treatment, which does improve overall outcomes. So all the guidelines now recommend that for any confirmed pancreatic cancer patients, they must undergo comprehensive germline testing. So I do germline testing in most of my patients, and you should consider that as well. So should we consider neoadjuvant therapy? Yes. What regimen or strategy? I think I tend to use FOLFIRINOX for fit patients and Gem/Nab-Paclitaxel for slightly borderline fit patients. And again, for pushing surgical boundaries, or even doing, we should consider enrolling the patient on a clinical trial. I think that is very important. So, okay, so let's take questions. Now I have to leave at 6:45 today. I'm really sorry. Let's go through. So Kanchan is, do we give routinely for every Whipples? No, you don't give it routinely for every Whipples, but I think most Whipples, it depends on the amount of pancreatic resection. I normally have a conversation with my surgical colleagues. And when the patient comes and sees me, you can do certain tests to see whether the patient does need creon or not. Basically, whether the fats are being digested with these enzymes, trypsin, chymotrypsin. That's very important. As per SWOG, Gem/Nab-Pacli looks better than, you're right, yes, and it is easier to administer. Should it be preferred in all, and in what patient subset should we prefer FOLFIRINOX? Shows DFS advantage, but absence of OS at what factors? So I think, it's a small study, and I think we need to still wait for more trials to say that Gem/Nab-Paclitaxel should be the standard of care. I would go with either or, but again, it makes us slightly reassured that Gem/Nab-Paclitaxel also is equally effective, because the adjuvant study with Gem/Nab-Paclitaxel, which we'll discuss next week, the APACT trial was negative. And the adjuvant trial with FOLFIRINOX was positive, which was practice changing. I mean, when I came back from ASCO, I remember I was working in London. We came back, we discussed in our MDT, and we changed practice even before the results came out. But the APACT trial with Gem/Nab-Paclitaxel was negative. So, just slightly concerned about that. Then Priopanc, yeah, it had borderline DFS advantage in adjuvant setting. What factors? So Priopanc was a new adjuvant study. So again, most of these trials have not shown an overall survival advantage, and but in like I said, in the subset analysis, it did show that there was advantage with chemoradiotherapy. What is your opinion regarding neoadjuvant of any chemo patient having LAPC? Again, so LAPC, as I discussed, the Alliance trial is giving FOLFIRINOX followed by capecitabine radiotherapy. So I tend to give 6 cycles of FOLFIRINOX, modified FOLFIRINOX, and then you stage, and if the patient is stable or has not progressed, then we go on to chemoradiotherapy with SBRT if possible, and then move on to surgery. And with that, I think the results are that it ranges from 15% to 50% patients are downstage. So I wouldn't let venous thrombosis stop you from that, but hopefully you can assess it down the line. So these patients will need a CT angiogram as well. So I think if that is all, let me know which papers you need. I will put it on the group. Next week, we'll discuss adjuvant therapy. If you have any questions, just ask. But I think the data is pretty convincing that most of our patients should receive neoadjuvant therapy. It's just convincing the surgeons. So, okay. Great. So let's meet next week, and I will discuss adjuvant therapy. If any of you wants to present